Good afternoon for those of you in the Eastern time zone, and good morning for everyone else. Thank you so much for joining us today for another edition of our Systems for Action Research in Progress webinar series. My name is Anna Hoover. I am the co-director of the Systems for Action National Coordinating Center here located at the University of Kentucky. And as you all know, Systems for Action is a national program of the Robert Wood Johnson Foundation, and it has been in the past closely connected with the prior Public Health Services and Systems Research National Program, which drew to a close last year. But today we are very, very pleased to have some researchers from that program who are going to share with us some findings funded through that prior Public Health Services and Systems Research Program. So our agenda for today is right in front of you, actually. I'm going to be handling the introduction and the traffic flow and generally acting as your cruise director for today's webinar. And we will be hearing from some terrific investigators from the state of Minnesota, Elizabeth Gyllstrom, who is a senior research scientist at the Minnesota Department of Health, and Rebekah Pratt, who is an assistant professor in the Department of Family Medicine and Community Health at the University of Minnesota. Following the presentation of findings from their research, we will be having commentary from Michael Stoto, who is a professor of Health Systems Administration and Population Health at Georgetown University, and from Alexander Brzezny, who is the health officer of the Grant County Health District in Washington. As you can see on your screen, you do have a chat box. If you have questions as the presentation moves along, please enter your questions in that chat box as we move. And when we get toward the end of our hour together here, we will be posing those questions for both our presenters and the commentators who will follow. So as a question occurs to you, don't wait until the presentation is over necessarily. Just go ahead and put it right in that chat box. And everyone will not be able to see it, but we at the Coordinating Center will be able to see it, and we'll make sure those get posed. In addition, we always have questions about the slides, and slides are made available after the webinar today. So with no more ado, I'm going to quickly introduce our speakers for the first portion of our webinar today. Elizabeth Gyllstrom is a senior research scientist in the Public Health Practice Section, Health Partnerships Division of the Minnesota Department of Health. Trained as an epidemiologist, she has extensive experience working with state and local public health data. Previously, Dr. Gyllstrom worked in the MDH Center for Health Statistics with a focus on maternal and child health research. She has been the principal investigator or co-PI of several public health services and systems research studies, and staffs the Minnesota Public Health Practice-Based Research Network. She will be joined by Rebekah Pratt, who is a faculty member in the Department of Family Medicine and Community Health at the University of Minnesota. Dr. Pratt is a community psychologist and works in the area of public health approaches to mental health. She has extensive experience in conducting qualitative and mixed methods work in health services research. Her work explores making important linkages between qualitative and quantitative data sets, which offers an important contribution to work that considers both the process change, the impact of interventions, and the interactions between both process and outcome-oriented data. Dr. Pratt is an expert and trainer in Vivo 10 software to facilitate qualitative data analysis and has additional expertise in the areas of health disparities, multimorbidity, and complexity. So with no further conversation for me, I'm going to hand the reins over to Beth and Rebekah.
Great, thanks, Anna. I am going to start things off. This is Beth Gyllstrom, and greetings from Minnesota, where it is actually pretty sunny and nice today. We'd like to talk with you today about local public health and primary care collaboration, which has really been rooted in a practice-based approach. First, I'd like to acknowledge the Robert Wood Johnson Foundation. We are a grantee, as Anna had said, of a previous Public Health Services and Systems Research National Program, but also want to acknowledge the local public health directors, local medical clinic directors and staff who have participated in our interviews and surveys, as well as all of those who've really been key in our practice-based research networks and have provided implementation guidance. So So just a little background. Certainly we're all, I think, pretty familiar with the 2012 IOM report on integrating primary care and public health. When we first set off on this project, we really didn't find a lot of information about the degree to which public health and primary care work together at the local level. Yet recognize that there is increasing pressure on both public health and primary care to collaborate. And really these increased expectations for efficiency and effectiveness of services and population health improvement. We were curious, though, about what might be some barriers to system integration, as well as while collaboration sounds great, it can also be challenging. So to that end, we decided to create our own collaborative, which for us has been a real strength of this study, in terms of pulling together practice-based research networks from both the primary care and public health sectors to work on the study and really lead it and be the study advisory committee, but also had 4 states. So while this is being led out of Minnesota, we have some really fantastic co-investigators from Washington State, Colorado, and Wisconsin. So just wanted to acknowledge all of that effort. So as you'll see with our little diagram, we had a multi-phase of this study. So the first was a qualitative phase where we conducted paired interviews in the 4 states with 40 local public health and primary care respondents. We also did a much broader survey and again engaging primary care and public health leaders, but really tried to get as many jurisdictions as we could across the 4 states. And really at this point we are now trying to meld our key findings both from the qualitative and quantitative results, hoping to take some of this dialogue and some of what we're learning and really translate it into some action steps. So starting off, we had these kind of key research questions, and I, right off the bat, want to draw attention to one of our first early learnings, and that is that integration is not really a beloved term on either the primary care or public health side. Tricky for us in terms of as we present on it, though, because all of our research questions were really couched using that phrase. But what we were really trying to get at is looking for variation across our local jurisdictions in this either degree of integration or our more preferred term of collaboration between primary care and public health. What barriers are out there and which of those may be most problematic? Does the perspective matter? What does primary care think versus what does public health think? Where are there similarities and where are there differences? And then, really, are there some action steps that could be taken to really promote this collaboration and overcome barriers and really focusing on keeping it grounded in a practice-based perspective? So as I noted with the survey implementation, we had a sample that was drawn from 241 local health department jurisdictions. So we used the local health department entity to define the jurisdiction. In some instances, we oversampled on the primary care side, so had multiple respondents identified within a jurisdiction to try to increase that response rate. And actually one of the, I think, secondary benefits of that approach for our primary care folks is that there was not necessarily universal practice-based research network coverage in each state on the primary care side. And so our primary care investigators in the other states really put a lot of time and effort into trying to identify clinic leaders in those jurisdictions where they didn't already have these relationships, which I think has had this secondary benefit of really increasing their potential reach in their states. I should probably give a shout out to Wisconsin, who really went the extra mile on that piece. But that's really what comes into, as you look at these response rates, why we have both an overall response rate for primary care, but also a geographic specifics. That really gets at in which jurisdictions did we have a primary care respondent. And so although our overall response rate was about 31%, we did have about 50% of all of those jurisdictions represented by a primary care representative. Our survey itself was about 38 items. It was an online survey and very parallel, but really looking at these collaboration factors from both perspectives. So in terms of our methods, we did a lot of frequency distributions just looking at the public health and primary care data sets separately, but we were also able to create dyads where we had at least one representative from within each jurisdiction. There ended up being about 71 dyads, which is about 29 or 30% of that overall set of jurisdictions. So we looked a lot at percent agreement and the correlation of responses between the respondents within each dyad. And then we also used the public health, the primary care, and the dyad data sets to give you a little teaser here, to place jurisdictions within a multidimensional model of integration. We'll get back to that. So when I talk about this multidimensional model, which is coming soon, what we really started to notice is that there may be kind of two buckets of features or characteristics that seem important to these partnerships, which we are calling foundational and energizing. And so we went through quite a process to assign questions to those two buckets and create values and use them to create scores to really be able to position our jurisdictions within this new emerging framework. Just a quick shot of kind of who this sample ended up being in terms of when we're thinking about these jurisdictions. I just wanted to draw your attention first on that upper line. When we look at our full set of potential jurisdictions, we're looking to see, okay, well, how well does the public health only, the primary care only, or the dyad seem to reflect that full set of potential jurisdictions? And we see that, our primary care only really was more focused in larger population areas, and then our public health only does seem to line up perhaps a little bit more closely to our full set. So that's something that we've been thinking about as we think about, okay, well, which data set is, the right one to use? Maybe there isn't a right one, but certainly something that we are thinking about. So in terms of some of the things we've learned, both from the qualitative and quantitative data, as I alluded to, some of these aspects of partnership really are building and maintaining a foundation. Some of these activities, though, seem more action-oriented or energizing, and we don't necessarily see that whether you're doing something necessarily correlates with how satisfied you are with that relationship. Overall, it seemed like most respondents felt like, collaboration is important, but we're starting to feel that this relationship is probably not a linear relationship, and that as we're thinking about our model, that it's perhaps a little bit more dynamic, and it may be that jurisdictions move in and out, or these relationships move in and out of these relationship quadrants. So we're starting to really think about these collaborations on this two-dimensional model. So on your lower left would be those that they're relatively weak with regard to both foundational characteristics and with energizing characteristics. So they maybe aren't coming together that frequently on projects or even on clients. They don't have any sustainability features in terms of staffing or financial commitment. They also really lack formal structures. And then this idea of, that you hear a lot in partnership literature about, do you have a shared vision, trust, respect, and value? Those elements aren't necessarily there. On that lower right-hand corner would represent partnerships that are stronger on the foundation, so they may have those shared vision, trust, respect, might have some supportive leadership, but they may not actually be doing any tangible work together. So they may say, oh yeah, we think primary care or public health is great. Of course we want to work together. We very much value and respect those opinions, but there isn't really much going on. In that upper left-hand corner would be really the converse of that. They haven't necessarily invested in those things that we've seen in the literature build relationships, but they might come together on a specific client to address a crisis. They may have some features in place that allow them to work together and some leadership that actually directs the work. Finally, that upper right-hand quadrant is really where they pull it all together, and they've got both foundational and energizing aspects of the relationship. And so we were really curious to see, okay, well, what happens when we create these scores? Where do our jurisdictions fall? And so in each of these quadrants, the top line is using our public health only data. The second line is using the primary care only data. And the third line is if we use our dyads to try to place these jurisdictions. And you'll see there's a fair amount of variation in where they land depending on who's responding. With public health, I think, being more optimistic, perhaps, than primary care's view of the world. So that raises some questions of, well, boy, we're seeing a fair amount of variation. And so, it's making us think, well, which picture do we take? And I don't know that there necessarily is a right picture. One of the things we did note is that when you look at the public health only, when we asked this group to self-rate their degree of working together, it's pretty close in terms of that highest quartile of work and what they say whether they're working together consistently or not. And as I think about, too, that more of our primary care representatives are coming from a larger geographic area, it may be harder for them to speak to that overall relationship because they may not have that bird's eye view of the whole jurisdiction in the same way that a local health department would. And they also have a more variation in roles represented. But I kind of think that the distribution probably falls somewhere in between and probably is, as we're seeing, is somewhat dynamic. It may be changing. And I would hate to suggest that we would discount either perspective because I think both perspectives are really important and valuable if we're going to be promoting the work. So I just wanted to give a quick snapshot of some of the quadrant characteristics associated just with this public health data set. So this is the larger sample size. To me, it's a little bit interesting that when you look at whether or not the health department is a standalone or versus a within agency structure, those that seem to have the lowest energy or the lowest amount of working together are those that are in a combined agency as opposed to being in a standalone. And then also to draw your attention, when you look at the jurisdiction type, that low energy but high, or low foundation but high energy, there doesn't seem to be as big of a difference between whether it's a single or a multi-county. They're pretty relatively distributed between the two. And we just have a couple more characteristics as well. Another thing that jumped out to me was when you look at that high foundation and high energy group, they are the most likely to report either a very consistent working relationship across all of their clinics or kind of a generally the same. So we asked our public health respondents, how do you actually work with your clinics? Does it vary a lot? And so it was very interesting to me that those that seem to be in that highest quadrant seem relatively consistent within their jurisdictions as well. So I am now going to turn it over to Dr. Pratt to talk about barriers.
Thank you. So as we are thinking about this framework and the ways in which energizing and foundational characteristics might interact to influence the way in which folks might come together to collaborate, we understand that there might be a bird's eye view and that people might be able to use this framework to think about how their relationship is formed in general. People have also given us a lot of positive feedback about the potential value of that framework approach to thinking about the ways in which they may even come together around particular topics or activities or projects. So we've had a lot of really encouraging feedback as we've been consulting with the potential user community about this framework. But invariably, a question that always arises as we talk about the framework, and it's a wonderful question, is how do people move from one part of this framework to the other? What would help somebody in their partnership move from being in one of the less active, low foundational areas into having more solid foundation and more directed action in their relationship? And in that leads us to the question of what gets in the way when people are stuck somewhere they're not hoping to be. What kind of barriers do they need to overcome to really elevate their work and build their relationship towards greater collaboration? So what we'd like to do is just talk about some of the key barriers that we have observed. One of the things I'll note about the qualitative piece of this work is we really, and I think this is a distinguishing feature of this project, is we engaged people who had a wide variety of relationships. People who might be working very closely together and well, or those folks that we might know as the exemplars in the field. And I think they characterize a lot of what we see in published work on this topic. So we decided to search a little bit more broadly and engage people whose relationships also might be less well-formed or have kind of challenges, to ask them too about what gets in the way. So some of the barriers that people raised with us were very much related to aspects of the partnership that they had with each other. Communication emerged as a really common barrier, finding ways in which to be able to communicate and share with each other across public health and primary care. And in some ways, I think that the increasing emphasis on having electronic health records and great health-related IT systems puts this into sharper irony for sites that even though there might be greater technology, there's no way to make that talk between the two partners. And that can be a real frustration. Very closely related to that, challenges around being able to share data and being able to share information together. And as you'll have noticed from our framework, that being able to come together around shared data and information for the purpose of thinking about how to prioritize action together is very important. So it's not surprising to us that where that data is hard to share and the communication is difficult, that forms a real barrier. A lack of a prior partnership is an issue, as is that lack of developing a shared priority. There's nothing like a data-driven shared priority to really focus action. And so that lack of shared priorities is really a tremendous barrier when people are thinking about how to come together for better collaboration. And I think one of the things that emerged quite clearly from our data is that a key barrier to forming a partnership is not understanding each other. And I couldn't emphasize enough how much of a barrier that can be. And I think for both fields, primary care and public health, there's a real sense of the field being going through a tremendous amount of change and evolution right now. So maybe it can be challenging to understand ourselves. But really taking the time to fully understand what each partner brings to the table, their skills and knowledge, was a significant barrier as described by some of our partners. Now, if I move on to the next slide, you'll see that really a second kind of type of barrier emerged, and we are referring to those as system-related barriers. And that constant change that I just mentioned features quite large as a barrier in there, because it's very difficult when navigating a lot of change within your own field to then work out how you define that relationship with a different field. And both public health and primary care are undergoing quite a lot of change in their own right. That not only makes it hard to understand each other, but it can lead to a little bit of a fatigue in terms of dealing with finding the energy to make further changes and build relationships. The funding environment was mentioned as an issue, and some folks face what we've termed geographic challenges in terms of the areas that they physically serve. So a public health department might provide coverage across a very large geographic area, and that can come with a certain number of challenges for building the relationship. Many of the barriers, and both primary care and public health articulated this very clearly, related to the primary care context. And for an example, we have a quote there talking about the fact that you may have primary care relationships as public health, but you might be dealing with 3 different electronic health records just in the one small area. So that system can be quite fragmented. Primary care is under a unique level of strain in terms of productivity and a unusually sharp sense of change being underway with health reform. Primary care is sort of under siege, as it were, at the moment, and both public health and primary care are very sensitized to that being a barrier. Resources emerged as an issue, but certainly not the only issue. Resources are not surprising to be mentioned as an issue, and both public health and primary care talked about the need for systems change to help improve working relationships. Now, as we think about how we move forward and take action around this, one of the potential areas for action would be to focus on ways to build foundational capacity for partners. Our research would indicate that that would mean there's certain key value activities such as connecting together around building relationships with existing resources and understanding. A real asset to this potential collaboration was the role of public health as a neutral convener across many health systems that they may cover, and how that might be a really strong asset to build upon. Finding ways to support the mission and priorities of primary care as it's developing, and of course developing IT and communication capacity seems like an easy win, as does having leader commitment to supporting collaboration. Likewise, if we think about taking action and building energizing capacity, it's quite clear that finding a way to draw on data to develop strategic planning processes, community health assessments, to draw aligned goals and activities can be a big win for public health and primary care coming together. And we'll talk about some specific examples of that next. But engaging in joint program work and opportunities to build relationships. Quite often people told us of the value of a health crisis, how flu outbreaks really meant they got to know each other. And taking those as opportunities to build and elevate relationships shows us that we can find other ways to build those ways to come together, whether it's around looking for some shared resources, looking for grant funding, finding ways to become involved in innovations together deliberately to form ways to build relationships. In relation to thinking about stakeholder perspectives, there's a real need for consistency between partners, and that's a real challenge when both disciplines are under a certain amount of flux right now. Finding ways to align health goals and work on joint grant proposals. An area of serious consideration is to find opportunities to do joint strategic planning, because both public health and primary care often are under strategic planning requirements. These, though, typically do not have aligned timeframes. So finding ways to come together to join resources and activities to make the most of the fact that both are required to do such planning and find a way to use it to elevate their relationship, along with dedicated funding and finding ways to further develop a toolkit of ideas. So in conclusion, we clearly see in our data that both sectors really deeply value working together. There's much positive regard, respect and interest in working together, but there is a certain degree of uncertainty about how to take those next steps towards building relationships. And indeed, one of the things that we would argue is perhaps the collaborative framework that we're proposing might be one way to help partners think and reflect on where is our partnership at, and what kinds of ways we want to elevate our relationship to more productive working. There's a paradigm conflict in our data, and that we see really quite different perspectives from public health and primary care. And how do we find ways to understand and navigate that? We see that there's high levels of satisfaction with the relationship right now, but very different levels of the amount of time public health and primary care are actually working together. And so taking some time to ask ourselves, what does it mean to be satisfied about not working together? That's a real paradigm conflict that perhaps needs to be brought out and explored a little bit further to move this along. Public health might be more traditionally grounded in community outreach and coalition building, and primary care sees the value in the partnership as they continue to identify shared priorities, finding ways to draw on both of those assets from both fields to complement and energize each other's work. I'd just like to touch briefly too on some of our limitations in this study. Certainly there were some challenges in engaging primary care respondents. I can widely attest to that as the primary care research representative today. It's difficult for primary care to participate in research for many reasons, and it has a slight impact on our data today. So that's a challenge for us who are primary care oriented to take that further. And interviews focused on local jurisdictions where investigators at least knew some collaboration existed. And that may have meant that we missed additional issues that would have been raised in jurisdictions with little or no collaborative work. So there's still work to do in understanding what happens when there is no relationship at all. The interview times were limited and may have missed some important modifiable barriers. In saying that, we did receive a wonderful depth of data. I'm very grateful for everybody's thoughtful time and contribution. As we think onwards about the implications for policy and practice in this work, in many ways we've raised questions that need further exploration, and so continuing to do further work and understanding how to overcome the barriers we've identified, and perhaps seeing the value of separating those out as foundational and energizing different types of barriers to help guide us through getting better insight into that. There's a need for more research around the return on investment of greater integration and collaboration. Certainly policy could support finding incentives and creating deliberate opportunities to bring together collaboration and integrating activities. We don't have to wait for flu crises. Perhaps we could incentivize the deliberate coming together more systematically. Attending to both the primary care and public health context and limitations, knowing that these are both in flux right now and that we have to be nimble to respond to that. Continuing the development of information technologies and information sharing, finding ways to really make the most of what's a wonderful age of innovation with information, and thinking about how do we build that for this field, and thinking about leader development for collaboration. In terms of our next steps on the study will be completed in the fall of this year. At the moment, we will continue our focus on translation and dissemination activities, including thinking about future research questions. And that includes thinking about how this model can be applied to other sectors and other partnerships that aren't just primary care and public health related, but how do these insights from these two dynamic fields help us understand other types of collaborations? Clearly, the model we have developed, we're getting requests and interest in further exploring that as a potential toolkit where we can dig into each of those quadrants and find ways to support partnerships, navigate thoughtful ways to addressing the barriers, identifying the levels of their relationship, and thinking about how to move forward. So that's work that is yet to be done, along with continuing to finish our writing and analysis time. So for more information, we have been talking about this work in a number of settings, so we'd encourage you to search on the terms there, and you'll find many kind of archived presentations and abstracts, or feel free to contact ourselves as listed there. We have a project update posted just now on the webinar for your attention as well. So thank you very much, and I think we'll now move on to our commentary.
Thank you, Rebekah and Beth. Thank you so much. This is Anna again, and I just do want to point out to folks who are watching online, the web capture that you see here is the project page for this research. Every project funded through the Public Health Services and Systems Research Program, as well as through the Public Health Practice-Based Research Program, still has a live site on the PHSSR website. This one is for this Minnesota project. It contains presentations and other dissemination materials for each of those web pages has for that specific project. So we really try to archive and keep those as current as possible, and encourage you to pay a visit to the PHSSR website if you haven't been there lately. As we prepare to pivot to our commentators for today's presentation, I'm going to quickly introduce both of our respected speakers. Dr. Michael Stoto is a professor of Health Systems Administration and Population Health at Georgetown University. He is a statistician and health services researcher who holds faculty appointments in the Department of Family Medicine, where he is the Associate Director of the Population Health Scholars Program, and the Georgetown University Law Center. Dr. Stoto is an expert on public health systems research, applying and developing rigorous mixed methods approaches to studying and evaluating federal, state, and local public health systems. His recent PHSR work has focused on public health emergency preparedness, regionalization in public health, the evaluation of biosurveillance methods, and the development of methods for assessing emergency preparedness capabilities based on exercises and actual events. Dr. Stoto's work in population health and public health assessment includes developing methods for evaluating community health assessments and performance measures to help hospitals and state and local health departments in the Washington, D.C. metro area develop community health needs assessment. Following Dr. Stoto, we'll be hearing from Alexander Brzezny, who has served as the health officer for the Grant County Health District in Washington since 2001 and is a family medicine physician in Ephrata, Washington. His experiences include that of European healthcare and public health systems and other international experiences, including a visiting study at the University of Iceland and the University of Minas Gerais, Brazil, which I am sure I butchered, but that was my best attempt. So I will now hand the microphone over to Dr. Stoto, who will be followed by Dr. Brzezny. Mike?
Well, thank you very much, and also thanks to Beth and Rebekah for a great presentation. I really think that the work that they spoke about was really terrific in two different respects. First, in terms of the research methods, what it does is demonstrate the power of the kind of rigorous qualitative research using formal methods that they used across the board. And I think I probably would include the survey work as qualitative as well as the interview work, and they really got a lot out of that. I'll come back to that in a moment. The second thing, though, is that I think it moves beyond the focus that PHSSR research tends to focus on the health department as a unit of analysis and also the unit of production in health. And it really goes to the role of public health and primary care collaborating with one another and with others in the production of population health. And I think that focusing on this is really something that can be useful for health departments that are really working hard to find ways to collaborate with the healthcare delivery system and primary care in particular in their communities. And I think this represents an important contribution to growing literature on this important topic. Substantively, the thing that struck me in reading this is how closely their findings relate to the work that Kania and Kramer have done on what's called collective impact. And I'm sure that Rebekah and Beth are aware of this, although they didn't mention it. Now, my summary of their key characteristics of success are understanding and communication, shared priorities, alignment of goals and activities, data sharing, shared resources and staffing, and health departments as neutral conveners. And I think that really maps quite nicely onto the 5 things that Kania and Kramer have found to be effective for collective impact: having a common agenda, having continuous communication, having mutually reinforcing activities, having a shared measurement systems, and having a backbone support or organizations. Now, in my own work, I've argued that community health needs assessments that nonprofit hospitals are now required to do as a condition of the IRS and through the Affordable Care Act, and that health departments seeking accreditation are required to do, that these needs assessments and health assessments provide an opportunity for exactly the kind of collaboration. So it was interesting to hear the mention of that, and if we had more time, I'd like to know whether there was more about how well they are working or could be working in this context. And let me just finish by saying that I think that what this leads us to is another question, as good research often does, and that is, how do we accomplish these goals? How do we actually bring about the kind of collaboration that we talk about? And I would say that what this takes is really a different kind of qualitative research, one based more on doing in-depth case studies where we identify models of different communities where there is effective collaboration, and try to understand by looking across those what are some of the common principles or the best practices, and what are the kind of successful models that work in different contexts. And I think that the work that was presented today really is great at generating hypotheses about that. But the way that we're really going to understand how to do it, how these models work, is going to take further in-depth work of that kind. So I'll stop at that point. Again, thanks for the presentations.
Thank you, Dr. Stoto. Dr. Brzezny?
Yes, thank you. And also thank you for the excellent research and for the invitation to share my thoughts. I would perhaps approach it from a maybe more local perspective, as I currently sit in a primary care office, and I'm about to see my patients today, and have been just yesterday in my health district work as a public health officer. As we in our county and also in our state go about trying to align or perhaps even integrate primary care with public health, I couldn't help myself when I was reading this research to realize again why we do see quite diverse degree of responses in the dyads in primary care and public health. In fact, those are two, in my view, as I've approached it, and this research has confirmed for me, those are two corporate worlds in two different phases of development. And even though we both strive to work together and we recognize the importance of it, I think public health is probably a bit ahead of that process. Public health, we tend to align around common goals, population and programs in general. We have more of an eagle's view of what's going on in our communities. We understand partnerships. We know how to write grants and work on programs. And we, in fact, have allegiance along the same lines with local and state, perhaps governmental public health, what I would call, driving us in that direction of healthier and better communities. And then you meet primary care, and I must tell you, I know very well why your responses were less optimistic. Primary care, in my view, is undergoing the degree of change that is qualitative and very deep and very transformative. The primary care is being asked to divest itself of seeing patients and being paid per encounter, so-called fee-for-service, to a value-based system, a more comprehensive and coordinated system. And in fact, in my assessment of this research, I have realized that we have a very divergent groups of physicians and primary care providers as well as practices. We have large systems that are consolidating, employing providers to perform a service, very similar to what any business would do. You have physicians or providers who see patients, diagnose and treat, and that's their daily, that's the expectation on them. Then you have the smaller groups. You have hospital-based physicians. You have small practices. You have urban and rural. And in fact, they don't necessarily converge on the same issues. They are feeling they are at this point threatened by the changes that are being requested of them. They know that they may be on the hook for reduction in payments. They indeed compete. Unlike public health, primary care compete within their own communities for the very patients without the eagle's view that the public health has. I would not want to underestimate, as we go about primary care public health alignment, this profound change that primary care is currently undergoing that I think is deeper than the changes we in public health are asked to bring about. I will in fact state that I think there are two primary cares. There are providers, physicians, mid-levels, and others who see patients and provide service. And there is the other primary care, which is the administrative part of that. In fact, that aligns well with what you were talking about, your systemic issues in terms of bringing about change, which I think probably, in my view, should be brought on the administrative level of primary care. And then you have the more of a individually energizing sort of issues that may be brought and more successful on the provider's level. It is a small wonder that collaboration between primary care and public health is not linear. I think the amount of divergence and diversity in primary care, and in fact the severe changes that are occurring might be a challenge for us, but also a great opportunity, I think, if we do and are able to translate this research into a value to primary care. So I think it's important to present the alignment and coordination on services and health of populations as a value to primary care. When I was thinking about this, I do like the collaboration framework as perhaps a tool that individual communities, and I am very specific about individual communities, not very in decentralized fashion on a local level, could use to assess the degree of their preparedness or degree where they are in terms of alignment on these services. So the 4-square collaboration framework, I think, brings a lot to the table, and it seems to me as a useful tool to see how do we move to show where we are and where do we need to go. I will point out that in the recent research done on primary care physicians, about 50% experience burnout. Generally, morale is low. They feel overregulated. They feel paperwork is significant. They feel the electronic record, so often mentioned as something we see as beneficial, is actually a hindrance to their work. So that's the different languages we speak. We see this as a value. The primary care may see this as a significant hindrance to what is occurring. And maybe I will end with the observations I've had on the two primary cares, being providers and the administration. I think that in terms of the providers, I think what I think the research is pointing out, that there might be two different groups of interventions that this process could focus on. I believe on a provider level, on a provider primary care, the coalescing around common issues is where I think this research is pointing we could go. On issues like vaccination, opioids, education, antibiotic stewardship, obesity. I think that's where providers, as overwhelmed and as threatened as they feel, that's where they get the spark. That's where they are more likely to come and work with us. As far as common goals, which is more of a systems issue on data sharing, communication, legislative and policy work, that is better done, I think, with the primary care administration. And I think the physician and other providers, I think, would appreciate if that was not something they would work on, which I think has been, at least in our experience, on local level. Perhaps I say that the public health as a facilitator needs to recognize that role, and we really need to see public health initiating, coming to the table. I think the other way at this point is going to be very difficult to expect. I think public health needs to initiate, instigate, get into committees in the hospitals and local clinics, infection control committees, pharmacy committees, integrate itself into healthcare setting, as opposed to expecting that the primary care is ready to do this. As I was reading this research, again, the divergence of opinion and the barriers as they were presented in a sort of twofold fashion, I think reflect on what I was earlier stating about more of the provider-focused services provision primary care, and the systems which have gotten so complicated in primary care that physicians and others who provide services have pretty much given that up to someone else to take care of. And so show value, come to the table, and your interventions or our interventions need to reflect the differences and the significant challenges in primary care at this time. Thank you.
Thank you, Dr. Brzezny. And I'm going to give Drs. Gyllstrom and Pratt an opportunity to respond in just a moment. But while I do that, I'd like to remind folks to please go ahead and enter your questions into the chat box, and we'll be getting to those in just a moment. To that end, I would like to go ahead and again give Beth and Rebekah an opportunity to respond either to Dr. Brzezny's discussion just now of the integration of public health personnel into primary care settings through committees and other sources, or the heterogeneity of perspectives involved in the findings, or perhaps to Dr. Stoto's earlier comments on the relevance to collective impact research, or to future directions being potentially really in-depth case studies to flesh more of this out. So that's a big playing field. While folks are writing their questions in, I'd like to volunteer to give Beth and Rebekah an opportunity to volunteer some thoughts about those discussions.
Thank you, and I just want to say thank you to both Dr. Brzezny and Dr. Stoto for those wonderful reflections. I think Dr. Brzezny's comments for me pick up on an issue that we need to overcome in terms of thinking about it from a primary care perspective. I would kind of almost refer to those two different levels as being able to find a way to articulate what this means for the point of service encounters that providers have day to day and patient by patient, as well as what it means from a systems perspective. And I think we need to do a lot more to find ways to think about it from those quite different perspectives, but they're also very closely connected as well. And part of that, I think, is around continuing to develop a common language. And for me, coming together in this project with the two different types of PBRNs has been completely integral to being able to explore how we, on even the study team, develop a type of common language to think about those different levels of interaction and how we can find a way to articulate that meaningfully.
Yeah, I also wanted to thank both of our commentators. Really appreciated your feedback and, thinking back, Mike, to some of your comments, both around collective impact and, those parallels, and I think kind of that idea of who's the backbone organization and I guess coming from a public health perspective, I would, say, well, maybe public health should be that backbone organization, which I think also then echoes, Alex, your comments about who's going to initiate coming to the table. But also I think, Mike, your whole we all, think for the most part collaboration is good. I know we've really tried in this study to not assume it always is, but thinking about how do we go to that next step of actually accomplishing it, given all of the challenges that both of these fields face. And I think that's what we're thinking about right now is how do we take what we're learning, because certainly when we've taken this out to stakeholder groups, whether it be policymakers or practitioners, that's really been the question is, okay, well, what next? So that's kind of where we're sitting right now as well.
Thank you both for those thoughts. We do have a few questions in the queue that I will begin putting out there. The first is from Gianfranco Pizzino, who has a question about the tables on slides 18 and 19, and he's curious as to whether those are the result of univariate or multivariate analyses. And there's a follow-up. There's a potential follow-up, but I'll let you answer that part first.
Sure. Yeah, so those are just straight distributions, Gianfranco, of univariate. And we are doing some multivariate. We haven't got all of that complete. So that's just basically if you're looking at the distribution across those quadrants, where do they fall? But I do think one of the things that we found was really, really tricky in this, and I think some of our commentators have alluded to it, and we've talked about it as well, is this idea of system versus local on the primary care side, and then also this idea of, well, what does the public health jurisdiction look like? And, it could be that a multi-county jurisdiction, if it is covered by, say, one system, might be more effective at working together. Or, you might have the single jurisdiction with one clinic might have an easier time of it. It's really that at what level do you build relationships and how do you build them? And I think teasing all of that out is kind of half the trick of all of this, but it's not maybe a one-size-fits-all answer. So anyway, that's my longer response to yes, it was univariate.
All right.
This is Mike. I just like to say it's probably about 3/4 or maybe 80 or 90% of the trick. one size doesn't fit all. Context matters so much in these things.
Mm-hmm.
And that sort of leads us into Jim Franco's follow-up question, which was, to what extent associations, for example, multi-jurisdictional agencies having low energizing factors, be the result of confounding effects, like agency size and others. And
Sure.
I think that those are obviously areas for exploration.
Yep, absolutely. Could very well be the case.
All right, we have a couple of questions that show some interest in this area of study and some potential areas for spanning out or replicating some of this work. The first is from Von de Reynoso in California, who would like to know if Dr. Stoto could repeat the reference he gave regarding common collaboration earlier.
Yes, the work is by Kania and Kramer, K-A-N-I-A, and Kramer is K-R-A-M-E-R. It was published in Stanford Business Innovation Review, I think, what it was in 2011. Maybe the others can correct that. Maybe we can get that specific reference out to the participants later. I think it's an important one.
Okay, excellent. We'll make a note of that here at the Coordinating Center. Also interested in working in this area, I think we hear from Dave Palm, who wonders if it's possible to get a copy of the interview protocol.
Absolutely. Yep.
Excellent.
Yeah, maybe just email me. My contact info is in the slides, or Rebekah.
And as we wind down in time here, I'd like to share some information and a question from Ruta Valaitis in Canada, who thanks you for a great presentation and notes that your results mirror work that they've done in Canada, and has posted a toolkit link that they're going to be releasing next week, and that should be in your chat box. We could probably get that out as well with the reference that Mike was just mentioning. This toolkit was built on primary care and public health collaboration care studies in Canada. And Ruta says that the fear in Canada by public health is that their resources for population health interventions will be lost to the management of acute care issues, and wonders if that's a concern for the U.S.
So I'm kind of chuckling because I think we already spend a lot more money on health care as opposed to population health. So, we would hate to lose any more public health funding, but I think kind of the reverse is maybe more the current situation here. We spend a lot more on our actual healthcare dollars than we do on prevention currently. I don't know, Rebekah, if you have a...
I suppose I would add that that there's much talk and interest in the primary care community right now about how to think outside the walls of their clinic, how to connect outside to what some people might call the medical neighbourhood, to interagency working to public health to address the health needs of their patients. But there's real challenges about actually how to do that, and a general sense of being a little bit overwhelmed at the prospect of doing that. So it might be that there's some similar concerns, but I think a little bit different context too, potentially.
Well, thanks to you both, and thanks to everyone who listened in and participated. I'm going to take the opportunity of that mention of the toolkit from the Canadian research group to mention that the PHSSR website also has some toolkits developed from findings related to PHSSR and PBRN work. And there's going to be a poster about that from HRIA and NNPAHI, who spearheaded that work last year at NACHO next week. So for those of you who are going to NACHO, be sure to stop by and check out that poster on toolkits related to PHSSR and PBRN work. You can see here on your screen the link to learn more about archived webinars as well as any upcoming events. We want to thank you all for joining us for today's webinar. I want to say a special word of thanks to Ann Kelly, our program manager here at Systems for Action, who does so much work behind the scenes to make these webinars happen, and has just really led this effort, and we appreciate her work greatly. Thanks to all of you. Be looking for the slides from this. They'll be sent out to everyone who attended, and we look forward to seeing you for our next webinar. Thank you all so very much. Have a great day.